Good afternoon. This is Deborah Miller. I'm with the Council of State Governments. Thank you very much for joining us today. Our webinar today is on essential health benefits. I'd like to welcome you to that call. Let me go through a little housekeeping and then we'll turn it over to our speaker for the day. Everyone attending the webinar will be in a listen-only mode. There should be a box. It usually shows up in the upper right corner of your screen into which you can type questions. You can type those questions at any time during the webinar. They'll come to us here in Lexington, Kentucky, and we'll sort of consolidate them as they come in and use those questions to have a discussion with the speaker when she's finished. By about the end of this week, we will have the PowerPoint slides and the audio posted on our website. Those of you who are attending the webinar right now, and maybe your colleagues who signed up and have been unable to attend, will receive email notices with the link to that. Those of you who just want to get on there on your own, you can also always get to it through both our Knowledge Center and our home page by going to the webinar site, and you can see past webinars. So that being said, I'd like to introduce Paul Giagiardi. He is the Director of the Office of Intergovernmental and External Affairs at the Department of Health and Human Services. He and his colleagues in that office have been very helpful to us here at CSG. This is the second in a series of webinars that we've been doing to build state policymakers' understanding of the Affordable Care Act and implementation facing states in the next year or two. So without further ado, Paul, take it away.
Great, thanks Deb, and good afternoon, everybody. Thank you for joining us today. As Deb mentioned, this is the second in a series of webinars that we're partnering with CSG on the implementation of the Affordable Care Act, and we hope that we are providing you with much valuable information for state legislators and other policymakers in the states as we continue to implement the ACA. As you know, the Affordable Care Act is a law that gives states a lot of flexibility and leeway in how they implement certain provisions in their states. This is particularly true as it relates to the health insurance exchanges, and an important element of that are the essential health benefits, which is the subject of our webinar today. So we have with us today a very esteemed guest, Sherry Glied, who many of you may know is the Assistant Secretary for Planning and Evaluation here at HHS. She is the person who spearheaded the process through which we developed our recent release bulletin on essential health benefits. And so she is going to take you through our current thinking as it relates to the EHBs and give you some indication of where we're headed for next steps. And we'll be able to answer any questions that you may have. We appreciate all of the feedback that we've gotten from state policymakers and from non-governmental stakeholders throughout an extensive process dating back to last summer into the fall. And your feedback really did inform our decision-making around essential health benefits, and I hope that you will see that reflected in the guidance that we put out today. So with that, I'll turn it over to Sherry, who will walk you through the presentation, and then we look forward to your questions.
Thank you, Paul. Good afternoon, everyone. Good morning to those of you still on the West Coast. I'm Sherry Glied. I'm Assistant Secretary for Planning and Evaluation, and we work very closely with CSIO, the Center on Consumer Information and Insurance Oversight, in developing this Essential Health Benefits Bulletin, which lays out our intended approach to the regulation of essential health benefits. What I'm going to do today is talk a little bit about how we got to where we got, what our position right now is in terms of the intended approach and the next steps that we intend to take. So let me begin with the first slide. Click. Okay. The legislation, the Affordable Care Act, tasks the Secretary with defining what the essential health benefits are to be. And it does it with several elements. First of all, it defines 10 categories of services that have to be included in the definition of EHBs. And then it lays down 2 criteria for those EHBs. The first is that the scope of benefits in the EHB should be equal to that covered under a typical employer plan. And the second is that the development of EHBs consider balance and discrimination and the healthcare needs of diverse segments of the population. So 2 distinct categories there. I want to note, when we started out, the first thing I asked when I got here was I asked our lawyers, what does a typical employer plan mean? What does it mean to say typical employer plan? And they said there is no statutory, there's no legislative meaning of that. We don't know exactly what it means. We'll have to figure out a definition of typical employer plan, and that's part of what we went through in trying to work out this EHB definition. What does typical mean? So if you turn to the next page, it lays out the 10 categories that are defined in the statute as required to be covered under the essential health benefit. And you'll notice here that it has the standard categories that we expect in pretty much all plans, as well as additional services like habilitative services and pediatric services that I will come to later on are somewhat less common in plans today. Next slide, please. So essential health benefits are intended to apply to many different kinds of plans that will be developed. First of all, both in the individual and small group markets, whether the markets are inside the new health insurance exchanges or they're outside the exchanges, that is, they're offered by small employers who do not participate in the exchange or by insurers who do not participate in the exchange, all of those plans must cover the essential health benefits. As well, Medicaid benchmark plans and benchmark equivalent plans must cover the essential health benefits, as must basic health programs. So the scope of effect of the essential health benefits is quite broad in terms of affecting all of those markets for both individual and small group coverage, and including Medicaid. Next slide, please. In trying to figure out what should be included in the essential health benefits, the department took a number of significant steps. The first thing that we did in trying to define typicality was that we looked at some data that the Department of Labor had been collecting for many years on the characteristics of employer-sponsored coverage. So the Department of Labor has abstracted information on plans, and they provided us with a report on what kinds of benefits are included in employer-sponsored coverage across those plans. We held a series of public listening sessions across the country this fall in many different areas, hearing from people about what they felt needed to be in essential health benefits, hearing from both consumers and providers to get a sense of, and employers to get a sense of what health benefits should cover. And we contracted with the Institute of Medicine, which is an expert group here in Washington, asking them to help us come up with recommendations on the process for defining and updating the essential health benefits. Next slide, please. So we first got back the information from the Institute of Medicine, and the IOM laid out a basic principle for how we should be thinking about essential health benefits, and they said what you really want to be doing is balancing comprehensiveness and affordability, and that's really the mantra that we've taken as we move forward with this as well. So they said start with the typical small employer plan in today's market. So making a decision right there that we should be looking at the small employer market, not the large employer market. So there had been various discussions around that, but the IOM strongly recommended that we begin with the typical small employer plan and then adjust that plan to ensure that all the 10 categories specified in the statute are included. The IOM also encouraged us to monitor implementation and to update the process for defining essential health benefits, and you'll see that as we developed our own guidance here, we took that very much into account. And the final recommendation that I want to emphasize from the IOM is that they really encouraged us to provide states with latitude and flexibility so that they could come up with essential health benefits packages that were most appropriate for the needs of the people within that state. So the IOM really also stressed this idea of flexibility and latitude for innovation. Next slide, please. The next thing that we did is review everything we could possibly find about what kind of benefits are currently offered out there in the world. So as I mentioned earlier, we asked the Department of Labor to look at the survey that it's already been collecting. It's a nationally representative survey of about 3,000 employers of all sizes, in which employers provide the Department of Labor with plan brochures and the Department of Labor can look and see what benefits are actually provided in all of those plans. In addition to that, the Institute of Medicine, as part of its efforts, surveyed 3 small group insurers, issuers that have products in many, many areas of the country, to look at the benefits that they typically offer. There are existing national surveys run by the Kaiser Family Foundation and by Mercer Consulting. We looked at what those surveys told us about the benefits that are typically covered in plans. Then we now have a website, healthcare.gov. Visit it if you haven't been there already. And that website includes information from over 1,900 different small group products in all the states. So we looked at the information available on healthcare.gov about those products, as well as whatever information we could get about publicly about state and federal employee plans. So we looked at a very broad range of information on benefits, really trying to get at this question of what is typical. What we found, next slide, was in some ways very encouraging and comforting, which is that generally speaking, the plans and products that are out there in the world mostly cover the 10 statutory categories that are specified in the statute. I suppose that isn't really very surprising. If you look at that list of statutory categories, with a few exceptions, you would really anticipate that a decent health insurance plan would include hospital care, inpatient care, outpatient care, prescription drugs, and so forth. And in fact, that's what we find. Most plans do cover all of these categories, with the exceptions of habilitative services, pediatric vision, and dental care. I should note as well that some plans in the individual market, not in the small group market, but in the individual market, have narrower benefits. But as you'll recall, the statute asks us to develop a plan based on the typical employer plan, and so that's going to mean that benefits are a little bit more comprehensive in an employer, because benefits are a little bit more comprehensive in an employer plan than is sometimes the case in the individual market. That is captured in our definition here. Now, you may be surprised on the, I just said that the plans look very similar, but you may be surprised by that because you've probably heard that plans cost very different amounts in different markets, and that's true. But it turns out that most of the difference in the cost of plans comes about because of cost-sharing differences in the plans, what we call benefit design, as well as limitations on benefits rather than on what benefits are covered. So the difference between large employer plans and small employer plans, and between small employer plans in one state and in another state, are not so much in terms of whether they cover hospital care or not, or whether they cover prescription drugs or not. What the difference is really derived from is what is the deductible on the plan, what kind of cost sharing is there for services. And those issues of benefit design around cost sharing and deductibles, all of those cost sharing components of benefit design are not addressed in the definition of essential health benefits at all. That is not part of this piece of guidance. That will be coming out later in terms, and it's actually laid out in the statute, in terms of the kinds of cost sharing that are to be provided in the exchanges. So it is cost sharing rather than the scope of benefits that really distinguishes plans around the country. And since we put the Essential Health Benefits Bulletin out, other surveys have been done, and generally they find results very consistent with this, showing that essentially all plans are covering very, very similar types of benefits. Next slide, please. So now there are some differences that I do want to point out, because a few very specific services do vary across markets. Some plans, some large group plans, cover some services that are often not covered in smaller group plans, and these would tend to be things like acupuncture, some bariatric surgery, and hearing aids. And on the other hand, some small group plans, because they are subject to state benefit mandates, do cover some services that are not generally covered by large self-insured plans that are not subject to those mandates. And the two that really strike us were in vitro fertilization and applied behavior analysis therapy for autism. Those are two benefits that are sometimes included in state plans, in small employer plans because they are mandated, but are not frequently included in large employer plans, although they sometimes are there as well. So there's some variation there. So that sort of tells you how we got to where we got, with one caveat that one more piece that I'll come to. I want to talk now about what we did next. We took the IOM's advice. Next slide, please. and thought about balancing comprehensiveness, affordability, and state flexibility. And with all of that in mind and taking into account the public input that we had received, we released in mid-December a bulletin on our intended regulatory approach to defining essential health benefits. Most of you, I hope, have seen the bulletin. It's available, you can see at the bottom of the slide, on the CSGovts website. In conjunction with that, in late January, we released an illustrative list of the largest small group products. And just recently, we released frequently asked questions around the essential health benefits design. So, next slide. In coming up with a plan, we tried to balance a lot of different ideas that had come out of this process of public engagement, the IOM, the Department of Labor, and our own thinking. We knew that we had to cover the 10 categories. We knew we had to think about typicality, balance, discrimination, diverse healthcare needs. And then we had the legislation is quite clear that mental health and substance abuse services are to be provided at parity because of the national parity legislation, MPIA. So that was another underlying principle behind this. We wanted to have flexibility available to states, and we wanted to make sure that we took into account the IOM's recommendation that we balance comprehensiveness and affordability. Now, in thinking all of that through, we came to one interesting, I think, conclusion, which was that if you look at benefit plans themselves, they don't really follow a what I would call a Chinese menu approach, one from column A, one from column B, one from column C. Instead, issuers get together, issuers look at the scope of benefits as an integral, holistic decision. They try to think about a package of benefits that they're going to offer. Once we had kind of realized that the package of benefits idea was probably the best way to think about this problem, we were led to thinking about it in a way that I think is a little different than where we had started, which was to use a benchmark approach. So next slide. So that rather than defining a set of specific benefits that would apply uniformly across the nation, we would define EHBs by a benchmark plan that was to be selected in each state, selected by each state. And this is very similar to the approach that is currently used for the Children's Health Insurance Program and for certain Medicaid populations. So basically, this takes advantage of the fact that issuers are already engaged in the design of benefit packages. And that to think about a typical benefit package is a more useful exercise than to think of a typical set of benefits. A package is a better way to think about this. And that's really the sort of the logic behind the benchmark approach that we took. Next slide, please. So the benchmark, we offered a fairly broad range of benchmark options. We told states they could choose any one of the 3 largest small group plans operating in a state, any one of the 3 largest state employee plans operating in that state, one of the 3 largest federal employee plans, and in order to afford states the opportunity to match their CHIP and Medicaid benefits with their essential health benefits in the exchange, we also included the largest HMO plan offered in the state's commercial market. That is one of the benchmark standards for the CHIP benefit. So states could choose the same benefit design, the same benefit benchmark for all of the plans operating in the state. Next slide, please. The plan is that a state will select a single benchmark which will apply in both years 2014 and 2015. And that benchmark, which is just a set of benefits included in one of those plans, whichever plan the state chooses as a benchmark, that benchmark defines the complete set of benefits that all applicable plans offered in the individual and small group markets have to provide. So to give you a sense of what that means, if the selected benchmark plan offers 10 physical therapy visits, then the EHB includes 10 physical therapy visits. So it's just whatever the set of benefits included in the plan applies. If a state chooses not to select a benchmark health plan, then the default benchmark plan for that state would be the largest small group plan by enrollment. So there is a default here in state. Okay, next slide, please. The state is to choose, as I said, for example, any one of the 3 largest small group plans. And the question is, when do you determine which plan is one of the 3 largest small group plans? The benchmark options are to be based on enrollment as of March 31st, 2012. And the plan is that the state select that benchmark and, as I'll talk about in a minute, supplement that benchmark as necessary by the 3rd quarter of 2012. If they don't do that, we will assume that they are not actually acting to choose a benchmark and the default benchmark will apply. We are currently evaluating options for the reporting of benchmark selections and benefits. We haven't proposed any guidance on that yet. Next slide, please. I think one of the issues that has been of concern to states and to us as well in terms of thinking through this process is what to do with state benefit mandates. There's a lot of concerns, both pro and con, about benefit mandates. The law, the Affordable Care Act, requires states to defray the cost of certain state mandates that are not included in a essential health benefit plan. So the question is, how does that interact with the approach that we've taken here? So here's where the guidance has come out. State mandates that were enacted before December 31st, 2011, that are in place and are applicable to the benchmark plan, those will be considered part of essential health benefits. That means, as they're part of essential health benefits, that states do not have to defray the cost of any of those mandates if they select a state insurance, an insurance plan that includes those mandates. So a state that chooses, for example, the small group plan with the largest enrollment will not be required to defray the cost of any state mandates included in that plan. If a state chose a benchmark that did not include a mandate, it would be required to defray the cost of any state mandates not included in that benchmark plan. This approach to state mandates is intended to be a 2-year transitional approach for 2014 and 2015. We will be watching very carefully to try and understand how all of this plays out and to define a new approach going forward from there. Next slide, please. The benchmark plan that covers EHBs must provide coverage for all 10 of the statutory categories. But what happens if a state chooses a benchmark plan, that's the largest small group plan, for example, and that benchmark plan is lacking one of the statutory categories? For example, suppose that it does not include pediatric, vision, and dental, or some other benchmark. They're going to have to supplement that benchmark in order to make up the full list of 10 categories. I'll come back to pediatric, dental, and vision and habilitative services in a minute. If a benchmark is lacking any other one of the statutory categories, it should supplement it by choosing a different benchmark option. So, for example, if the benchmark that you choose does not include hospital services, it's hard to imagine, but imagine such a thing, in the small group plan that you select as the benchmark, it doesn't have hospital services in it, you would choose the hospital services from another benchmark option, for example, from FEHB. Third, mental health and substance abuse parity applies in the definition of EHBs. So if a benchmark plan does not include mental health and substance abuse services at parity, that plan would have to be adjusted so that parity did apply to those benefits. Okay, next slide, please. There are 2 specific exceptions to the story that I just told you. One of them is habilitative services. Habilitative services is just a less well-defined concept, and we don't, so we wanted to provide a little bit more guidance about how to approach that issue. The bulletin identified 2 intended options. One is that a plan could provide habilitative services by saying that habilitation was at parity with rehabilitation services. So whatever rehabilitation services were available within the plan to restore functioning, those benefits would also be available to people to maintain functioning. A second option is that plans themselves would decide which habilitative services to cover and would report on that coverage to HHS as a transitional approach. So we put forward in the bulletin 2 potential options around habilitative services. With respect to next slide, please. With respect to pediatric, dental, and vision, we offered 2 choices for dental services. Either the largest federal employees dental program plan by enrollment, or the dental options are available in a separate CHIP program if a state runs a separate CHIP program. In either case, non-medically necessary orthodontia benefits would not be included in essential health benefits. Our intended option with respect to vision services is the largest federal employees dental and vision plan by enrollment. Next slide, please. The EHBs define the 10 categories of benefits, and we've suggested in our intended regulatory approach that health plans must offer benefits that are substantially equal to the benefits in the benchmark plan, but that may be modified as necessary. So, for example, so an issuer could modify the services offered within a benchmark as long as they met the CHIP standards for actuarial equivalence and complied with the discrimination and balance provisions of the law. What does that mean? If you think about the rehabilitative and habilitative services benchmark, you could think about a plan that is, imagine a benchmark plan that has 10 physical therapy visits and 20 occupational therapy visits. An issuer could decide, alternatively, to offer, say, 15 physical therapy and 15 occupational therapy visits, assuming that that was actuarially equivalent. And that would still meet the essential health benefit standard under this benefit design flexibility provision. Next. The state Medicaid agency is to select the benchmark, it's EHB benchmark reference plan, and it may select any Section 1937 benchmark plans as its EHB benchmark. That means the state's largest non-Medicaid HMO, the state employee health plan, or the FEHB Blue Cross Blue Shield plan. As you can see, those are 3 of the categories that are also included in the standard benchmark option. So there are opportunities for a state to have the same scope of services for both Medicaid and exchange plans. Again, if the EHB benchmark plan lacks coverage in one or more of the 10 categories, it must be supplemented. And there is no default for the essential health benefits benchmark in Medicaid. Next slide, please. We intend to periodically assess the EHBs and how they're doing and report to Congress whether enrollees have any difficulty with access because of coverage or cost, and whether changes in medical evidence or scientific advancement should lead us to revisit the essential health benefits. In any case, we will have to revisit the approach outlined in the bulletin for 2016 because the intended approach covers only 2014 and 2015 in terms of designing the benchmark. Next slide, please. Since putting the bulletin out, we've received about 8,000 comments. We're busy reading them all, and some of the key areas that people commented on were the issue of substitution of benefits within a category, how to incorporate dollar and non-dollar limits, what to do about state mandates, the timeline and process for the state selection of the benchmark, and application to the Medicaid program. Next slide, please. We also got a lot of comments from states, and probably the most prevalent comment was that states really appreciated the flexibility of this benchmark approach, which allows them to tailor the essential health benefits benchmark to the conditions in their own state. They particularly requested more detail on mandates, applicability to Medicaid, timelines, and the scope of the essential health benefits. Because of this, we actually released the frequently asked questions just last week on the essential health benefits. Next page. So what we're going to do next is analyze all the public comments, and we plan to move into rulemaking and issue regulations around the essential health benefits. We also released guidance on calculating actuarial value last Friday, which really speaks to the cost-sharing provisions, and there will be IRS guidance on the provision of minimum value by employer sponsored coverage in the near future. So let me stop there with that overview and take any questions. Thanks.
All right. Well, we have a number of questions coming in, so keep your fingers busy. If we get through these, we'll have time to ask for some more. From Maryland, the first question is, will the 10 categories that every essential benefits plan will be required to have be spelled out in greater detail? And if so, when can that detail be expected?
We do plan to release regulations that will define the essential health benefits with more, in somewhat more detail soon. But I don't think that we will be planning to release a great deal of granularity around what exactly fits into the categories.
Okay. And is that also true of the Habilitative Services category? Again, somebody specifically asking for some more detail on the autism behavioral therapy piece.
So what we've suggested in the bulletin is 2 options for Habilitative Services, neither of which is very specific in terms of the specific services that must be covered. One suggests that a plan would take the services it's currently requiring for rehabilitation and also offer those same services with the same limits and so on for habilitative services. And the second is that issuers could come up with their own definition of habilitative services.
Okay. The next question, if affordability is truly a goal, how does the state select a benchmark plan from existing plans in the state that covers all the state-passed mandates? And in parentheses, we have Rhode Island has 70 mandates. So how does the plan magically become affordable in 2013 if it's not affordable today? So I think this gets to the question of multi-state mandates and how to fold them in.
Okay, I'm not sure about the second part of your question, but let me go to the first part first. We did a lot of analysis on mandates when we started this out, and one of the things that we learned is that although there are lots and lots of mandates out there, many of them are benefits that have already been picked up by large employer plans voluntarily in any case. So when we compared mandated benefits with the benefits that are currently offered in the Federal Employees Plan, for example, the only two that consistently struck us as not being included in an FEHB, but as being included in through many state mandates, or IVF and applied behavioral analysis for autism. For the most part, most mandates that are on the books in states have essentially been superseded by insurer practice in the large group market. They're already offering those benefits in any case. So I think that's one thing to keep in mind around mandates. A second thing to keep in mind, and we've done some analysis in ASPE on this, is that the basic core set of benefits that are required, hospital, physician, prescription drug, diagnostic imaging, and labs, account for about 95% of the cost of the health plan. All the other things are actually quite small relative to the cost of the health plan. So that's another consideration to take into account. Now, certainly, states. Certainly, states have the option, if they want to avoid those mandates that are already required, of choosing one of the benchmark options that doesn't include the mandates. In that case, though, it would be important for them to pull those mandates back, because otherwise they would have to defray the cost of any mandates in excess of the essential health benefits.
Okay. From Illinois. If a state feels that benefits are inadequate in one of the 10 categories that is included in the chosen benchmark, will the state be able to substitute that benefit from another benchmark plan?
So this is something that will be worked out in the final regulations. Our thinking at this point is that if the benefits are there in the benchmark plan, they would be included. So we don't really want, our intention is to take benchmark plans as they are currently constructed, but this will be laid out in more detail in the final reg, in the regulations themselves.
Okay. Another question is, how does CMS, CIO, foresee monitoring the plans to ensure that they meet the categorical requirements, in particular perhaps with respect to children and the benefits that are least likely to be included for kids, including the habilitative services and oral and vision services?
So the proposed approach suggests that states, not the federal government, will have the responsibility of overseeing the content of the plans and making sure that they comply with the statute.
Okay, here's another question. Did the analysis, I guess that's your analysis, or the IOM analysis on the presence of the 10 categories in typical plans, also include an analysis of scope, amount, and duration of benefits? And the questioner says, we're concerned about comprehensiveness.
So our focus in comparing benefits across markets was on whether the benefits were included or not. There are differences in scope, amount, and duration of benefits in different plans, and it will be important for states as they select the benchmark plan to be looking at those differences in scope, duration, and comprehensiveness.
Here's a very technical question who even admits that they're an attorney asking this question. For clarity, if a state legislature is enacting a new benefit during the current legislative session, will these new mandates be included in the benchmark plan designated, if the benchmark plan is designated in the third quarter of 2012 and the new mandate law is effective at that time? I guess he's asking, or she's asking, if there's a way to slip another state mandate in.
Well, I don't know if I should.
Okay.
Okay. No. The short answer is no. The only mandates that would be included in the essential health benefits benchmark would be those that had already been enacted by the end of 2011, and therefore were already applying to plans when we do the assessment of enrollment at the end of March of 2012. So benefit mandates that are enacted or take effect after the end of 2011 would have to be, the cost of those mandates would have to be defrayed by the state if it chose when it chooses a benchmark.
Okay.
And
another
question. We will also revisit in 2016 this entire issue around mandates.
Ah, okay. From Arizona, will you elaborate on what is meant by states being required to defray the cost of state mandates that go beyond the EHB? For example, is it for all plans purchased in the exchange, all plans purchased when an individual gets a subsidy? Does it include state Medicaid plans?
We haven't addressed that issue in the bulletin to date, so I am not certain that I know the answer to it. It's certainly the case with respect to all of the plans that are sold in the exchange. I'm not sure whether it goes beyond that.
Okay. With regard to EHBs and the national parity law, will there be more clarity forthcoming with regard to requirements for a benchmark plan's coverage of non-severe mental illness?
I'm not certain what there will be on this in the proposed rule, so there may be more detail on it. Our expectation is that parity would apply to mental health and substance abuse benefits, meaning that any limitations on benefits for those services could only be there if they were equivalent limitations on the same services in general health care.
Well, we may have one more question coming in. The long one. While we're waiting for that last question, if the folks who have attended this webinar have questions for you all besides the general email URL, is there a person or an email sort of information box that they can send questions to?
Yes, you can either send questions to HHS-IEA at hhs.gov or to Essential Health Benefits at socio.cms.gov.
Okay, we have a follow-up question about the states monitoring their own plans, especially as it applies to coverage for pediatrics, oral and vision care, and habilitative care. What recourse is there if a state is not complying?
We haven't, there will have to be, I mean, the Secretary defines essential health benefits. There will be oversight by HHS of state action, but we haven't laid out how that will happen yet.
Okay. Okay. All right. Well, I think that pretty much takes care of the questions for the day. I really, really appreciate your all's participation here. These webinars are something that our members are quite interested in. We had 286 people sign up for this webinar, which is really a pretty good attendance, and so we'll be posting those. Oh, and someone just asked, could you repeat that contact information one more time? The email question.
Sure. You can either send them to Essential Health Benefits at ccii.cms.gov, or you can send them to HHS-IEA at hhs.gov.
Okay, thank you. Thank you very much. As I said earlier, we will be posting the slides, the audio from this. It will be available by the end of the week. And we thank everyone for participating. Keep an eye on our CSG website for upcoming webinars, and certainly let us know if there's a particular topic that you're interested in having more information on as states move forward toward implementation of the Affordable Care Act. So thank you very much. Have a wonderful day.
Thank you.
Thank you.